I'm David Gandera, and on behalf of the International Association for the Study of Lung Cancer, welcome to this World Conference. This is the 13th World Conference held by this association. You'll be interested to know that as of today, we have about 6,000 people registered, which will make this meeting by far the largest lung cancer meeting ever held in the world. So thank you for joining us today. The topic of this symposium is non-small cell lung cancer. Is it now multiple diseases? This is a CME activity. I'll talk to you a little bit more about the filling out the CME forms later. The learning objectives are shown here. So I will not go through them individually, but please take a look at them. Make sure we're doing our job. We have a distinguished faculty. Here's one. Oh, this is me. So I am David Gandera. I am from the University of California, Davis, and I am one of the conference co-chairs for this World Conference. Our other faculty, I could not be more pleased with the faculty that we have for this satellite. They are friends and colleagues, but more important than that, they are world-recognized experts in lung cancer. Dr. Chandra Balani from Penn State, Dr. Sarita Dubey from here at the University of California, San Francisco, Dr. Philip Bonomi from Rush University in Chicago, Dr. John Eckhart from Dava Oncology in Dallas, Dr. Bruce Johnson from the Dana-Farber Cancer Center in Boston, and a recent transplant to the West Coast, Dr. Alan Sandler, and you may expect to see Vanderbilt there, but he is now at the University of Oregon Health Sciences Center in Portland, Oregon. So we're going to begin and actually continue through this satellite to introduce each topic with a case. I know because this is an IASLC meeting that you come from all around the world. In fact, at these meetings, and I think it will be true here, it is approximately 1/3 participants from North America, about 1/3 from Europe, and about 1/3 from the rest of the world. Here at this conference, we have delegates from 87 different countries. So there is nothing like a case to put into perspective the discussion. So the first question for you, and these questions are really rhetorical because we're not going to have you try to answer. The panel, I think, likely will make comments about the cases, but we want to give you some things to think about. Would you still select any standard platinum doublet regimen? Would you select a platinum doublet regimen not containing gemcitabine, not containing pemetrexed? Would you go to a non-platinum doublet? Or would you offer erlotinib instead of chemotherapy? So for our first discussant, does histology matter with the use of cytotoxic chemotherapy? Yes, because we will have a point and counterpoint here. I asked Chandra Balani to come to the microphone. Thank you.
Good afternoon. Thank you, David. It's a pleasure to be here, and it's a pleasure to see all of you here at the first session. So histology does matter in today's date when we treat patients with advanced non-small cell lung cancer, not only with cytotoxic chemotherapy, but also with various targeted agents. And there is extreme importance relative to safety when we use the anti-angiogenic therapies, and there is need for adequate tissue sampling and validation of these molecular markers. So histology does matter when we choose a regimen for patients with non-small cell lung cancer. Thank you for your attention. And to give you the other perspective, our next speaker is Dr. Philip Bonomi, who is Chief of Medical Oncology at Rush Presbyterian, and he'll tell us the other perspective. Phil.
Chandra, thank you very much. You're always a hard act to follow, and especially when you have such a strong position to defend. But I'm going to bring up a few points that may cause everyone to think a little bit about this. Can we say that the predictive value, I'm not going to talk about the prediction as far as safety with an anti-angiogenic agent, but predictive value for efficacy, has it been validated in non-small cell lung cancer for pemetrexed? So what I'd say in conclusion, is histology predictive? Maybe. What I think we need is another prospective study in the frontline setting, looking at a pemetrexed regimen versus a non-pemetrexed regimen, and that's actually going on right now. Pemetrexed carbo-bevacizumab versus paclitaxel carbo-bevacizumab, very large study. That should give us further information and hopefully will validate this. How consistent is the interpretation by pathologists? Probably fair. And can we come up with better predictors? And I'm the eternal optimist. I think, in my opinion, it's a strong yes. But in fact, probably. Sometimes simple things do better than more complicated. So will a marker or a series of markers emerge that really give us predictive value in selecting the treatment for different chemotherapy regimens? We all certainly hope so. Thank you.
Thank you, Dr. Bonomi. So we've had a point-counterpoint now on this issue regarding histology. We're going to have our other panelists give commentary. So first I would like to ask for comments on this issue from John Eckhardt.
Thank you very much. And in looking at this, I don't know if the first time we're supposed to actually say who won the debate. Being actually, as you'll see, I'm at the end of the conference and I'm a con, I have a little soft heart for Dr. Milani and his opinions. But when I really look at this issue and say, does this matter? One of the biggest things that I think sways me is what's going to happen with my decision point in front of my patient today. One thing I do get is I do get today histology. The second thing I do know is that not that pemetrexed is better in non-squamous. That's good, but that's not enough for me. But what concerns me is this seems to be inferior in squamous histology, and that worries me because I don't necessarily want to do something that has potential toxicity and could potentially harm my patient. So when I look at this and I look at this debate, I think of the fact that the pemetrexed group that got the squamous did worse than giving other standard therapies. I do want to look at my histology, and I want to avoid using pemetrexed in those that actually express the squamous histology. If better markers may tell me exactly which patients do good or bad, I'll want to see that. But right now, I would like to see histology used.
And for a second comment, I'd like to call on Alan Sandler.
Thanks, David. So yes, I think that we've heard some compelling evidence of histology matter, that it does matter in terms of using pemetrexed in the non-squamous. What I think would be even more interesting is the theory has been about thymidylate synthase levels and whether those matter or not. And what would be even more interesting perhaps, instead of using 17th century technology, the microscope, to determine it, is maybe could we use thymidylate synthase levels? Are there patients with squamous cell histology that might potentially benefit from the use of pemetrexed if we understood what the thymidylate synthase levels were? And contralaterally, are there some folks with adenocarcinoma whose levels are actually higher than anticipated that might not benefit? And so it'd be interesting to look at that forward.